Introduction to Congenital Deafblindness. Deafblind Information Australia acknowledge the traditional owners of the lands on which this presentation was recorded. We pay respects to their elders past, present and emerging, and community members with deafblindness. Welcome to Deafblind Information Australia's training video series, made possible by an NDIS Information Linkages and Capacity Building, or ALC grant. My name is Melanie Robertson. This module is titled Introduction to Congenital Deafblindness. Project Officers. It was developed by myself and Emily McDonald, Project Officers and Deafblind Consultants. I am a practicing speech pathologist and Emily a practicing occupational therapist. This project is managed by Meredith Prain. Training modules. This presentation is part of the introductory series following on from Introduction to Vision Impairment and Introduction to Deaf, and Hard of Hearing. Module Overview. The module will explore definitions and causes of congenital deafblindness and suggested processes for early identification. Definitions. Deafblindness. Defining deafblindness has been and still is a topic of much discussion. Deafblind Australia, the national peak deafblind advocacy organisation, defines deafblindness as a unique and isolating sensory disability resulting from the combination of both hearing and vision loss or impairment. This has a significant effect on communication, socialisation, mobility and daily living. They argue that deafblindness is not defined by a certain level of hearing loss and vision impairment, but by the impact that any combination may have on any individual's function and access to information. The Nordic definition also includes a focus on the role of society and services. Deafblindness is a distinct disability. Deafblindness is a combined vision and hearing disability. It limits activities of a person and restricts full participation in society to such a degree that society is required to facilitate specific services, environmental alterations, and/or technology. This definition acknowledges that as a person with deafblindness living in a predominantly auditory and visual society, the dual sensory impairment reaches the point of deafblindness for an individual when specialist services, equipment, and adjustments are required to facilitate access to an otherwise highly inaccessible world. The implication is that if you have a degree of vision impairment and a degree of hearing loss, and you benefit from deafblind services and interventions, then you could be considered, from a clinical point of view, to have deafblindness, whether or not the individual themselves accepts the term. Any other names? You might come across these terms for deafblindness. The dual sensory loss tends to be used more for later onset or acquired deafblindness. Combined vision and hearing loss is sometimes used when someone does not identify with the term deafblindness. Congenital. The photograph on this slide shows a young girl sitting in a wheelchair by a flower garden, wearing a white dress with big red flowers. She is smiling. Indicators that she has deafblindness include a cochlear implant processor clipped to her dress, and the gaze from each of her eyes is not aligned. The word congenital means born with or present from birth. Combining this with a definition of deafblindness would lead you to think that congenital deafblindness would be easy to define and the condition readily identified. Let's explore this further. Congenital deafblindness. Depending on who is describing it, it can include those with presence of hearing loss and vision impairment from birth, before the age of 2, or before language is acquired, also termed prelingual deafblindness. Few definitions provide a cutoff point for vision or hearing levels for deafblindness due to the permutations and combinations that could occur and the individual's responses to these. Congenital deafblindness is also likely to occur with a number of other developmental challenges that may further influence a person's learning and participation. The syndrome-based definition. Congenital deafblindness has also been defined by the presence of a syndrome or condition that a child is born with that is commonly associated with deafblindness or known to result in deafblindness. This can include syndromes that include eye and ear conditions as defining features, syndromes causing vision or hearing loss from birth, and the likely onset of the loss of the other sense or loss of both senses at some point in development. It also includes syndromes commonly or historically associated with deafblindness. Such examples include Charge syndrome, Usher syndrome, and congenital rubella syndrome. While this assumption would be correct for many cases of Charge syndrome, some, but not all, with congenital rubella syndrome are born with deafblindness, and some may develop it later in life. For someone with Usher syndrome, the Usher genes are present at birth, and for most, so is the deafness, but the deafblindness is not. This comes later in development, usually after a degree of world knowledge, mobility, independence, socialization, and language has developed. When the hearing and vision losses develop depends on what type of Usher the person has. Why is diagnosis difficult? There are several reasons contributing to the difficulty of diagnosis of congenital deafblindness. Firstly, definitions in literature and research are inconsistent, and they may not state, or they may use different criteria to identify it. Secondly, there is vast diversity amongst individuals with their sensory combinations, their development across all domains, and any additional diagnosis they might have. Sensory function can also be difficult to determine with particular cognitive and behavioural profiles, so hearing loss or vision impairment may be missed and behaviour and development attributed to other developmental diagnoses. Criteria to assist identification. Ask Larson and Damon in 2014 suggest 4 criteria are needed to identify congenital deafblindness. These are the medical and functional assessment of the 2 senses, impact on mobility, access to information and communication, and the age of onset and a person's developmental levels at onset. Gathering such information, or where necessary, initiating the process for relevant assessment, will also help clinicians and service providers identify deafblindness where it may not initially have been suspected. Age and developmental levels at the onset of deafblindness is very helpful when trying to understand what world knowledge and skills that person might have already gained through having one or both senses. They have an understanding of a world that exists beyond their fingertips, and it is filled with things they have seen or heard, or seen and heard, yet perhaps never touched. Correct identification of deafblindness, whether it exists as a single diagnosis or as it sits amongst other diagnoses, would lead to a deeper understanding of the impact on development, will establish a mindset that this person's access to the world around them must always be considered, and opens up a scope of practice likely to be more effective in promoting an individual's participation, learning, relationships, and well-being. Dameyer, 2012, cites a case example which illustrates the identification process for a 12-year-old boy with cerebral palsy. He was unable to walk without assistance, had no spoken or signed language, and had severe intellectual disability with medical cause unknown. Ophthalmology assessment found no eye abnormalities. Teleacuity test was inconclusive. Functional assessment and observation of visual behaviours found he attended to moving objects more than inanimate objects. He was more attentive to visual stimuli on the right. Functional assessment results concluded cortical visual impairment and an estimated acuity at 630. His hearing was tested by otoacoustic emissions, with only occasional responses observed. No medical conclusion could be reached regarding hearing. Functional assessment indicated responses to voices and different musical instruments, and he favoured toys with sounds. There were also many sounds he did not respond to. Functional hearing was estimated at 60 to 70 decibels, and he was fitted with hearing aids. Social interaction and communication were observed when he was with his teachers. The boy's engagement with his teachers increased when they waited for a response or reaction and then guided his visual and auditory attention to the source. Tactile cues were introduced to guide attention, and tactile sign language was introduced to complement turn-taking and support dialogue. The functional findings supported a diagnosis of deafblindness. 2018 National USA Deafblind Count. This American registry collects data annually on children and youth with deafblindness. It includes children with the following combinations of vision and hearing diagnoses: documented vision loss, cortical vision impairment, documented hearing loss, central auditory processing disorder, and auditory neuropathy. Additional disabilities. Also noted in this report, about 1% of children with deafblindness in their database have a profound hearing loss and are totally blind. The other 99% have some residual hearing and/or vision. Approximately 87% have been identified as having one or more additional disabilities, the most common being cognitive and orthopedic disability and complex health needs. Causes in children. This slide displays a photo of a mother standing in a swimming pool holding her son against her chest. Both look at a large orange picture of a fish, helped by their physiotherapist conducting a hydrotherapy session. The boy, who has Charge syndrome, is holding an orange toy fish. They are all smiling. This US registry also identifies more than 70 causes, each with a relatively small incidence, the most common being complications of prematurity and Charge syndrome, each at 10% of cases. 19% have no determined cause. Genetics and syndromes. This slide displays a photograph of a physiotherapist kneeling on the floor using tactile prompts to assist a school-age girl to sit and balance on a low stool. The girl is wearing hearing aids held in place by a headband and is wearing glasses. She has Dandy-Walker syndrome. As mentioned earlier, congenital deafblindness can be the result of genetic inheritance or syndromes resulting from gene mutation, the most common being the syndromes of Charge, Downs, Usher, Stickler, Dandy-Walker, Goldenhar, and Cornelia de Lange syndromes, and Norrie disease. Charge syndrome is a rare genetic syndrome with an estimated Australian incidence of 1 to 2.8 per 10,000 births. The prevalence of Usher syndrome, types 1, 2, and 3, is between 3 to 17 per 100,000, with a 2010 study estimating up to 11% of children with deafness carry a genetic indicator for Usher. Before birth. This slide displays a photograph of a girl wearing a bright pink dress. A cochlear implant is visible on the right side of her head. She is sitting on the lap of a young lady, her carer, who is smiling and wearing a red t-shirt. She is holding her open hand towards the camera. Written on her palm is #StopCMV. Non-genetic causes occurring before birth include maternal infection, including the Storch infections, syphilis, toxoplasmosis, rubella, cytomegalovirus, and herpes. Currently, the most prevalent of these is cytomegalovirus. Maternal chickenpox, Zika virus, and diabetes have also caused deafblindness in utero. Other pre-birth causes include hydrocephaly, microcephaly, and encephalitis. After birth. This slide shows a school-age boy on a bright yellow wheelchair accessible swing. He is holding onto the bars of the swing and smiling. Childhood infections such as meningitis, low oxygen, severe head injury, and complications of prematurity are other cited causes of childhood deafblindness. Common causes in earlier generations. This slide contains a photo of a young man, Vladimir Kokol, with Down syndrome and deafblindness, taken from the 1971 documentary The Land of Silence and Darkness by Werner Herzog. Over the last 50 years, with the growth of medical interventions for infants and the development of vaccines and vaccination programs, there's been a shift in major causes of deafblindness, and the main causes in earlier generations are somewhat different to the major causes of today. The children of earlier generations born with congenital deafblindness, now the adults of today with congenital deafblindness, are more likely to have deafblindness resulting from congenital rubella syndrome, Down syndrome, and complications of preterm birth. Early identification. A 2006 survey of primary care physicians found that 1%, only 1%, reported that they referred children with hearing loss to ophthalmologists for vision assessment. The following have been suggested as ways to increase the identification of congenital and early onset deafblindness. Preparing educators of children who are deaf or hard of hearing to recognise signs of possible vision loss, including signs of typical and atypical visual behaviours. Ophthalmic and functional vision assessment for anyone with identified hearing loss. Conversely, children with diagnosed visual impairment should have their hearing regularly screened and followed up with full auditory assessment when needed. Checking vision and hearing assessment history when diagnosis or medical history indicates a condition or syndrome associated with deafblindness, and assist families to liaise with medical professionals involved to initiate referral for sensory assessment. Prevalence. The prevalence of congenital deafblindness in Australia is unknown. Data from Denmark estimates that 1 in 29,000 people have congenital deafblindness. In 2010, when Denmark published this data, the best estimate in children was 1 in 19,000, and in the adult population, those born with congenital deafblindness was found to be 1 in 34,000. Impact. The impact of congenital deafblindness is summarised by a quote from Muller in 2006. These children represent one of the lowest incidence, yet most diverse group of learners receiving early intervention and special education services. They make up an extremely heterogeneous group whose sensory losses are frequently accompanied by additional physical or cognitive disabilities, complex medical needs, and/or behaviour challenges. Deaf-blind does not equal deaf plus blind. Hearing and vision are known as distance senses, and they allow you to access information about things that are distant from you. This is in contrast to the tactile sense, where something has to be in contact with one's body or come from the body to enable use of this sense. If you lose one distance sense, you still have another that will provide you with some distance information. The impact of certain level of hearing loss plus the impact of a certain degree of vision impairment will not provide you with the impact of deaf-blindness for any particular individual. Part of compensating for a vision impairment involves using the sense of hearing to gain information that might be missed through vision, such as knowing who or what is around you by the sounds they make. Likewise, compensating for a hearing loss involves a heavy reliance on visual strategies, such as the use of sign language as a form of communication or lip reading to assist speech comprehension. Deaf-blindness distorts and fragments the compensatory senses, and therefore the impact of the whole can be said to be greater than the sum of its parts. Interaction and concept development. Studies of infants and young children with deaf-blindness have shown them to be less responsive to caregivers, exhibit few initiations to interact, have few opportunities to learn incidentally, and struggle to develop early concepts. Specialist interventions are required to support them and their families. An overview of these services and strategies is the topic of the next presentation. I wish to conclude this presentation with some quotes from Barbara Miles from the 1999 publication, Remarkable Conversations, a guide to developing meaningful communication with children and young adults who are deafblind. The first quote slide shows a photo image of a young child with a wide open smile, chubby clenched fists, and a joyful expression. He is wearing glasses and hearing devices. The next slide shows a photo image of a teenage girl in a wheelchair. A lady is crouching down beside her and holding one hand to her own nose and the other hand in the same gesture to the nose of the girl. They appear to be selling something. And to the quotes. People with deafblindness are connected in different ways. They know things that sighted and hearing people do not. They deserve to be heard and respected for what they have to say, however they say it, with language, with gesture, with movement, with voice, with hands, with eyes, with silence. The following 8 slides contain references which will also be made available on the Deafblind Information Australia website at www.deafblindinformation.org.au. Project officers can be contacted by email at info@deafblindinformation.org.au.